Get started in a moment. All right, and we got that notification that we are recording our session today. I think we have a good quorum, so we'll go ahead and kick things off here today. I am pleased to welcome everyone to our Academy session, Democratizing Data and Driving Self-Service Innovation at Intermountain Healthcare. Thank you all for joining us. My name is Rebecca Acabas, and I serve as the director on our Member Insights team here at the Academy. I'll set the stage for our context today, for our content, and then pass it over to our presenters. So just a few thoughts to kick us off. We know from our data at the Academy and obviously extensive conversations with you all and your organizations and executives across the C-suite that data and analytics, of course, is a top priority. And it's also a big priority for leaders across your organization at every level to help their teams access this data. But we know that it's not enough to invest in dashboards, tools to collect data and generate these reports, because even with the most sophisticated capabilities, they're really only as good as the insights they can provide to that end user. And in our first recent actually in-person meeting since COVID of all of our IT executives and forums, one of the key themes that was discussed there was how to demonstrate and measure value of the data and analytics enterprise. Because while I think we can all appreciate and understand the value proposition there, it can often be difficult to kind of translate that to frontline clinicians and employees and for them to unlock the value, particularly in a quick and easy way. So our session today is to discuss exactly that, how to make data more accessible and self-service so that end users who need answers can get them quickly, translate them into actionable insights and better outcomes for patients and the business. So we'll hear from 3 experts in this space who I will turn it over to in just a moment. But before I do that, a few housekeeping items for you all. So everyone's lines have been placed on mute, but we absolutely want to hear from you and encourage you to ask questions and share your thoughts and experiences as well through the chat function. I will be kind of teeing up those questions along the way for the presenters. So please don't be shy. We definitely, like I said, want to hear from you. And at the end, we will have some dedicated question and answer time. Again, we will be recording today's session and we will share a link to it with related materials in follow-up. We will also be sharing the slides as well in our communications. So without further ado, we just want to share our presenters with you today. So first up, we have Ziv Ofek, founder and CEO of MD Clone. Ziv is a leader in the e-health sector in Israel, and prior to MD Clone, he was founder and former chief innovation officer at DB Motion, which was acquired by or sold to Allscripts in 2013. We also have Dr. Mike Phillips. Mike, a clinical neuroradiologist by background, is now the managing partner of Intermountain Ventures. And Viet Le. Viet is a PA and researcher with the Intermountain Heart Institute, where he splits his time between seeing patients and doing research. We appreciate all of you being here with us today and sharing your expertise and experience. And without further ado, I'm going to pass it over to Ziv, who will get us started.
Thank you, Rebecca. Hello, I'm Ziv Ofek, founder and CEO of MD Clone. Today, I will review the data and analytics landscape and discuss the challenges that impact users from across the healthcare enterprise. In the last 3 decades, the healthcare IT industry has been focused on digitizing the healthcare data, mainly putting the data into machines and connecting the data silos around the individual patient. I had the privilege to be part of this evolution as a founder and chief innovation officer at DB Motion. But there is also a sense that as an industry, we've done a poor job in getting the data out of these machines. Today, after many decades and for all sorts of reasons, privacy risks, complex technology environments, multiple disorganized data sources, lack of skill sets to serve all the growing demand, and so on, healthcare data is still very much locked. Projects, including performance improvement and research efforts that require this data, can really be a nightmare. They are time-consuming, take months or years, resource-intensive, rigidly defined, skill-dependent, and regularly cause a lot of frustration. The result is a simple but poor outcome. Those who need the data, clinicians, data scientists, researchers, managers, entrepreneurs, can't get access to the data. And those who have the data, in most cases, can serve the growing needs and demand. What the industry needs is a new vision and a paradigm shift. We need an environment where, for the first time, any user, without any technology or data background, can ask any question, get the data in minutes instead of months or years, and immediately turn the data into insights and measurable actions. And while doing all of this, also ensuring complete patient privacy. The transformation will happen when, in any health organization, instead of having two people asking two questions and get the answers in 200 days, we will have 200 people asking 200 questions every single day. Such a self-service environment will turn any system to be a true learning system. This is exactly what MDClone does. The MDClone Adams platform provides health systems and life science organizations the ability to accelerate research, optimize operations, and drive innovation. Using Adams, end users can explore data freely and discover insights in minutes to improve quality, drive revenue, reduce costs, and implement changes. Three key elements enable MDClone's capability set. The first is a truly longitudinal data structure to organize healthcare data the same way healthcare happens, events on a timeline. The second is a self-service and highly flexible query, visualization, and intervention tools. And the third is synthetic data generation that allows users to securely share data and insights across the MDClone global network. Today, with a growing portfolio of happy top-tier customers in Israel, Canada, and US, we see our vision becomes a reality. Now I'll hand off to Dr. Mike Phillips, who will discuss how Intermountain is applying self-service principles. Mike, please.
Thanks, Ziv. So if you can go on to the next slide.
Sure.
And one more. Yeah, so I think for us, a big part of this was being able to get data to our frontline caregivers. And typically, my experience in the past, I've floated through a fair number of health systems, was that the data process went something like this. There was a question I needed to ask. I had no real access to sort of the enterprise data warehouse. I needed to pose my question, hand it off to someone who could write an SQL or an R query. That person would go ahead and run that query. They'd bring the data back to me and I'd say, well, this is really not what I intended to ask. And then we would work back and forth over a period of anywhere between 3 to 6 months. And we'd get a good query, we'd get good data out of the end, and it would be, cleaned up, very nice, ready to work on, potentially ready to be published. It's not that it didn't produce good data for us. It's just that it was a long time consuming process. And this had two effects. One was that it became kind of a bit of a standoff thing for folks. And two, I just believe a whole slew of people stopped asking questions. It became so difficult to do stuff that only when you had a really driving question, or you were publishing something, or you were writing a grant or whatever, would you really get into the system. So most folks really weren't in touch with data, and it was difficult enough for them, they gave up. And I think they lost a little of their curiosity because of it. The curiosity to understand really, sort of what is driving the care that I'm giving. What's the financial implication of the care that I'm giving? How can I see the effect of the change that I made in operations here? So in our case, we put a whole slew of things into the MDClone database. If we go to the next slide. So we have about 20 years worth of clinical data, about 16 million individual patients, something like that. 15 years worth of claims data from our insurance company, Select Health, is in there. We also have data from our internal accounting system, We have some limited but growing social determinants of health data, which is increasingly important. And we're getting more and more of the plain data from notes and reports and things like that in there as well. And it is, as Ziv talked about, all of this is organized in linear timelines for individual patients. So their insurance record, their clinical record, their social determinants of health data, all of those are individual timestamps that make a life journey for that patient. And that allows you to go ahead and design cohorts on the fly and answer questions. And we're able to put pretty much any kind of data in there, including unstructured data using an NLP tool. And this really, I think, caught the imagination of a lot of users at our place. So there are over 100 users. They range from frontline folks in nursing to docs to we actually have one medical writer who works for one of our researchers, a ton of folks who are in there, lots of use cases completed, and we'll talk about a few of those in a bit. And we really were able to identify a lot of potential savings. So, we have potential savings over about a 3-year time frame identified of about 50 million. We probably realized around 20 of that through work in kidney care and other things that we've done. And we continue to find more. And I think the great thing for us is we have a lot of very good care stories that we've been able to implement. And maybe as a quick example, and I'll talk about this in a little bit, in terms of kidney care, which is one of the first things we use this for, we look through our record for gaps in care. We identified 75,000 people in our system with some form of CKD. We identified 17,000 people inside our global system who were supposed to have seen a nephrologist, had never been referred. So these are folks who are falling through the cracks of our system. And it's typical for something like kidney disease because these folks are largely asymptomatic, right? They have abnormal creatinine numbers, but they don't really have any symptoms. They're just sort of walking around living their lives, but they're at a much, much higher risk to end up on dialysis, to end up with a ton of complications. We identified those people and we started putting them back on our care path. And it's had huge dividends for us in terms of their care. We have actually taken our rate of home dialysis patients, because we're identifying people early, from about 5% to about 40% now of our new patients enter into home dialysis. Increased our transplant rate. We've gone ahead and developed systems around self-care. And it all began with the ability to identify the population and identify the things that we were not doing for them. And because this is driven in a way where you have, for something like kidney care, it's not just a nephrologist who needs to know this, it's the kidney care coordinators, it's the APPs who work inside our system, it's all of the nursing staff in this, it's linking up the folks who work in our dialysis centers and the people who go visit our patients at homes when they go do home dialysis. They're all united by this one database, which allows them to follow patients and individually care for their portion of the care path. And that it just really totally enabled our team-based care around things like kidney disease, heart failure, diabetes, a whole slew of things that we've looked through. We've also used it to apply for grants. We've done some innovative projects with third parties. So we can go to the next one, Ziv. So I talked a little about kidney care. We also identified tons of gaps of care inside our diabetes patients. We use this actually as an initial program to start using Omada at our place to help people lose weight. We literally identified everyone inside the system with an elevated BMI and a hemoglobin A1C, which was greater than 6, but still below the level for diabetes. These are high-risk diabetic patients. They have a 60% chance of converting to diabetes within the next 3 years. We know that if we can have them lose weight, even a 1% loss in total body weight leads to a 10% reduction in the likelihood of conversion. So there's a huge opportunity there. So first we needed to identify all these patients, and then we use MD-Clone to follow them too. And we not only follow them for their weight loss, we follow them for how many times they show up in an urgent care, in the ER, how many times they're admitted to the hospital, all their total cost of healthcare in this group. And we're able to see that as we got this started, got these folks on weight loss programs, that the curve between typical conversion and what we see in this group has begun to part at about 6 months. So we know we're having an effect. We can institute a program like this and we can immediately follow it. And that's a huge thing for us, and everybody can see the data. So all of our diabetes care coordinators can see it. Our endocrinologists can see it. We can present it to our leadership and say, look, your investment for using Omada has paid off, tenfold in this. And this is where we predict the spend will be for these people in the years going forward. So those are just a couple of examples. We've worked on heart failure readmission, done a ton of, trials around just looking at individual treatment plans that we have. So, how are people responding to our hyperbaric therapy? We had one thing where we looked at the efficacy of a drug, and, in a specific population, we looked at the efficacy of a specific SGLT2 inhibitor in a group of patients. And it turned out that the effect was so small that it just simply wasn't worth putting the entire population on this drug. And we answered that in an afternoon, just from the historical data we had. So a lot of diversity and ability to really dig into questions. And the thing that we saw, which I found was sort of the most, or the coolest about this, was that once we got people into these systems and they saw the data they could look at, they really just sort of lit up. I mean, honestly, they said, I haven't been able to do this ever. And, we start them with one question and they're on to the next 20 questions that they want to ask. So it's a little bit of the joy of science and medicine, and for people to be able to have access to stuff, answer questions, and have their curiosity at least answered in the short run enough so that they're going to stay engaged and really want to do stuff. So you go to the next one. I think we may be going off to Dr. Lay here, or to Viet Lay. Viet, I'm going to hand it off to you.
All right, great. Oh, excellent. Those were wonderful points. So looks like there was a question in the chat there, Mike. That
would have required my ability to,
no. Just
to multitask.
Mike,
not there.
I can help out. There. I was saving it for the end. I was going to contextualize it a little bit more, but I guess we could take this as a brief pause. The question was directly, can you remind us what % of your patient population is covered by Select Health? But I guess I would kind of extrapolate that a bit to just, if you have any comments about what it means in the context of, either being a payer and or just like generally taking on risk versus organizations that may not be quite as far along on that journey, how you think about the use cases for data and what that means. If you could first answer the question, but then also just any musings.
Let me give you a sense of Intermountain. So right now, about 60% of our total revenue is from premium payments. So we're about 60% at full risk for the folks that we take care of across our system. And that's growing every year. 2 years ago, we were about 45. So rapidly growing and changing inside the system. So we definitely have a risk-based perspective. We still have 40% of our patients in a traditional fee-for-service kind of payment. What I would say is the tool is completely flexible. We tend to look at things in the focus of total cost of care, but we had someone else ask us recently about a group of payers and admissions for pneumonia. All right, from a different group of folks. The question they asked us is, what should we be doing with these? Should we find a different site of care? Should they move to a different hospital? All that sort of stuff. From a fee-for-service point of view, whether you have someone admitted for pneumonia to your hospital depends on what you're presently filling your beds with and how many of those beds are full. So the economics of this is all based around, if I can fill that bed with a knee surgery paying $45,000 or $60,000 versus admission for pneumonia at 12, I'd prefer to have the knee in that hospital if I'm a fee-for-service operator. I prefer that pneumonia patient to go to a hospital that doesn't have full beds, and it makes much more sense on an economic basis. They can be treated equally well in either place. You can answer that question very quickly using this tool. So the answer is very flexible tool. You just need to figure out what's important to you.
Yeah, that's great.
Thanks, Mike.
So let's see. It's a handsome picture. I don't know that I look that way anymore, but
You're looking good, and good background too. So.
Thank you. Can we go to the next slide there, Ziv? Okay, so my experience with MD Clone has been just wonderful. Everything that Mike has described has really fit the bill for me. I came to Intermountain in 2012, really as a occupational medicine PA, having done cardiology 7 years prior to that. But I did a lot of literature review, and I've had a chance to work with a previous version of Intermountain's electronic medical record, Tandem, and then Help One. And then over to CPRS Vista with the VA, or the Department of Veteran Affairs. And, it was so interesting coming over to Intermountain and doing research where we were supported quite well by several data analysts and had our own PhD researchers who were helping us to look at data. So, it was something that I'd never experienced before. To have that level of professionalism and expertise in both querying data as well as analyzing it in the human format. The problem became we were asking a lot of great questions because we had access to these individuals. And what ended up happening is that great time that we had asking a clinical question that made sense, that we wanted to report on, became 3, 6, 9, 12 months out on a queue. And by the time your question came back to you, you'd lost the passion and the nuance to why you actually asked the question in the first place. And then to Mike's point, even though we've been working together as partners and very closely with our query team, 20, 30 years, there were still some clinical nuances that weren't captured correctly in the query. So you'd get funny data that you'd have to work through, and it would take 2 to 3 more months to then hammer some of that out. What I like about this, in thinking of self-service, what that really did for me actually was take me to another level of understanding our enterprise data warehouse, understanding the data marts and what was actually captured. As a clinician, that's so important. We assume a lot from the electronic medical records. In this case, iCentra, our current version, is pretty neat. I know you'll probably not hear a lot of clinicians say that, but I actually like the electronic medical record and feel like I am a super user in my ability to look at data and query things and adjudicate outcomes for research. But I will tell you that being able to get into the data myself and using MD Clone has really taken me to another level of understanding the problems that the data analysts run into, and what query issues come up, understanding timing. And when you ask a question, was it meds before discharge, after discharge, well beyond? These are the things that we really need to think about as clinicians when we start to use a lot of resources in terms of human time. So using something like MD Clone really provides a way to level up your own understanding of the data. And then it makes those interactions with our specialist partners in data query and analysts, or analyzing data, so much better. I find that perhaps they're not as frustrated and anxiety driven when I come to them with a question. So let's see, let's go to the next slide. All right, so data access and project execution. We've said this, and I guess I can rehash it a little bit, but this idea that I'm in clinic, I have a question, and it's a very important question, but what ends up happening is the day-to-day clinician, because we don't have access to something like this, it's not readily available, we lose that question. And while it's important, it's clinically impactful, significant, and actually could drive care to a better place in a value-based system. I can see this working very well. But you lose the question because you can't find the individuals to help you. So the ability to have an idea, to go to MD Clone, begin asking the question, and get really just 30,000 foot level information that gives you insight into what next to ask and how much further to drive down, how granular can you get. That's important to me. So we're so curious as clinicians. I think we're trained for that because we're always asking what's going on here, what diseases is happening. And then we're constantly pushing the boundaries of good, better, best, and trying to understand the therapies that we implement. So as Mike mentioned, there's a lot of excitement around SGLT2 inhibitors. And to be able to look back at our own data and say, well, hold on, there is some excitement and there's some good things going on, but perhaps we do not use this expensive drug on everyone. And that, there's a certain cohort that it makes sense in the real world. Clinical trial data is a little bit different than the real world. There's so many other confounding variables. So it's so nice to be able to do that and have a clinical question that you can answer. You did it in an afternoon. So that's amazing. That's something that in general would have taken us, even sitting down to do a PICO question, a data query. We actually even have a sheet that we use, and then we would submit it. It would sit on the query list for 3-6 months, and by the time it came back, oh well, I don't actually know what I was thinking with that, and what variables are important here. So it helps to be able to reiterate quickly and iterate quickly your question and move at the speed of true clinical significance. I like the idea of tracking my patients prospectively. And we have a lipid clinic now where, some of the things you think you do a really good job of following guideline directed medical therapy. And you think you implement things, I'm the expert, I should know this, and I'm doing very well at this. But honestly, looking back and tracking things, you realize there's so many missed opportunities to be able to improve care. And that's at the specialty level. So think about what happens in the primary care and or general cardiology level of care for our patients. So lipid management is something that has been so important to me. We actually don't have another lipid clinic within Intermountain, except for the one that Dr. Anderson and I started a year and a half ago, just prior to, actually now 2 years, because it was before COVID. And we realized that there was at least this missing opportunity in guideline-directed medical therapy, but because I was looking at patient-level data as it came through, because I adjudicate a lot of patients that we're looking to enroll that have had heart attacks, that acute coronary syndrome, et cetera. So I was noticing a pattern as a human. That's where I realized we needed a lipid clinic. What MD Clone has allowed me to do is instead of looking at each chart individually for research purposes and then for the lipid clinic, now I can just ask, hey, of all the people who've had an NSTEMI or a STEMI, what are we doing with their lipids? Are we drawing lipid panels at the time that they're admitted? And then what happens 30 days afterwards? Did we start them on a high intensity statin? And are we checking to see if that has any impact? We know statins really improve care and reduce events. That's easy. That's not rocket science in terms of medicine, but what you don't track, what you don't measure, you can't change. And it would take forever to do it, in a traditional manner. But but doing point of care access through MD-Clone is very helpful. In the research world, what happens is when we have phase 3 trials and there's pharmaceutical companies that want to sponsor trials within our own system, and if we're interested, we need to know if we have the actual patient cohort that is being assessed for the trial. It took forever to do this in the past. We would, again, do a query, send it out. It would take 3 to 6 months. Well, by the time we got the data and we understood how many patients were actually eligible and send it into the trial sponsors, it was halfway enrolled by other centers. And we would have missed out on 6 months of enrollment, 6 months of training, and getting on board with a phase 3 trial. This particular example here with hypertriglyceridemia and lipoprotein A, I mean, how many of us know how many patients in our system have a triglyceride of 880 and have suffered a pancreatitis event in the past 15 months? Can you do that? And more to the point, can you do it right now, today, in the next 30 minutes? Well, that's what we found we could do. We were able to use MD-Clone, find our variables, and query the data. And it wasn't, I won't say it was perfect, but what it gave us was a sense of the patient population, that we had nearly 2,000-3,000 individuals that met that criteria across the system. And then we could level it down to our local valley and region and be able to reach out to them. And sure enough, we have been approved as a site. Same with the lipoprotein A. It's not a common lab test that's done, but it's something that we were able to review real quickly who was doing it and how many patients had an Lp(a) drawn and met the other inclusion criteria for the phase 3 trial. And we were approved to become a site. So I think that from a research standpoint, this is invaluable. From a point of care standpoint, I found it immensely helpful with regards to understanding our lipid clinic, what the scope of how we have to grow for Intermountain, and our, how we can process the patients that are out there to level up their care. So the last thing there, and I think I probably have another slide, but what we just recently did, working with Peter and some other members of the MD-Clone team, was I had a specific question of a group that's orphaned. Their ages are 20 to 39, and I really wanted to know, they don't fit in the current 2018 cholesterol guidelines, but if they have an LDL greater than 160, they're kind of risky, at least in the hypothesis of LDL and cardiovascular disease. It makes sense at 40 to 75. Why wouldn't it at 20 to 39? And are the more to the point, are these individuals folks that have familial hypercholesterolemia? And so what we actually did was took a look at all patients 20 to 39 in the year of 2010 and moved them all the way forward. So we had 10 years of follow-up data and looked at those below 160 and then those from 160 to 189. And we were able to compare how many events in each cohort and whether they were on statins, they were given statins, how long they stayed on it, what happened to their lipids. And long story short, since I've been talking a lot, there is a difference. And we've submitted that abstract to the American Heart Association conference. We'll see if it gets accepted, but I'm moving forward with the manuscript because I think this is very important, and Intermountain will, our patients, our community will benefit from us knowing this data, because now I have a reason to push forward and discuss these individuals, and I have the data for outcomes with our primary care providers in the community. Next slide, please. Okay, so I guess I've taken us to the question and answer period.
Yeah, that's great. We'll pop everyone back up, all our presenters, so we can go ahead and move into Q&A. Please, everyone, don't be shy. I'd love to hear from you in the chat, or if you do feel bold enough to pop off of mute, go ahead and you can jump in with a question. But before we while we wait, I guess, for those to come in, just a couple to get us started here. So Mike, this one's for you. I'm wondering if you could talk a little bit about, the title of our event today is about democratizing data. So when we say that, I mean, what does that actually mean to you? What does that look like? And then, what type of range of different users do you have? Vic gave us some really great examples on the ground. So if you could just speak to that a little bit to get us started here.
Yeah, I think that the concept of democratizing data, it was part of what we were actually anticipating when we got a medical record system. We ended up with a little bit more record and a little bit less information than we were hoping for. We were actually hoping for an information system to be able to help us get that data. What we have now, I think, is an overwhelming amount of data that is available, but the availability of it has such a long time constant to it that it's not practicable for anyone to use. So I think our ability to have everyone from the administrator for a clinic to a care coordinator who wants to understand their cadre of patients, to clinicians, to our finance folks, to ask a question pretty much today, right? Someone calls you up about a trial. They want to know whether you have enough patients with a specific set of characteristics. You call them back that afternoon and say, yeah, I've got 200 of them in this one clinic. We're all in. We'd love to do it. Or someone who calls to you and says something to the effect of, we just saw this new company, right? It looked like they have a great opportunity for us to go ahead and save on this particular operational detail. You can really tell them in an afternoon whether that actually makes any difference to us. Where in many cases that was really hard to know because, the company will come in, they'll pitch you, they'll tell you how great they're going to do and how they had this great experience at, place Y. Well, they don't look like you. So you can answer those kinds of business questions today, research questions, operational ones. And for those of us who get, and I know there are a lot of people on the phone call who get intermittent questions from their leadership at their hospital institution, which they are kind of expecting you to have a crystal ball and know. The CEO or the CFO calls you and says, gosh, I'd really love to know, how many people like this we have. Do we take care of a lot of those folks? And you go, I don't know. But now I query it for them and call them back that afternoon and tell them. So.
Yeah, the turnaround time certainly seems to be one of the biggest assets among many others, of course.
Yeah.
We did get a question here about the security risks and how you manage that, right? So I'll read it just so you have the benefit of the full question, but it seems like restricted access to data is often justified in the forms of gatekeepers, like IT analysts, so forth, as a means to mitigate the risk of data misuse. How did your security or risk folks get comfortable with more open access to this? So yeah, certainly a question and a topic we hear a lot
about. I can probably take a shot at that, and Ziv can also work through it. So then the folks who are users on MD Clone, you have to go through a process. We have a whole policy set up for users in the process of it. The vast majority of people are actually doing well-defined quality and clinical care work. So they would have access to fully identified data to begin with. For people who are not doing that, MD Clone will output the data as synthetic data. Our organization has put together a policy that synthetic data is not human subjects data or not PHI, which allows it to be viewed by virtually anyone. And so that's another huge point for MD Clone and the ability to allow folks to not have any issues with regard to security. And then the last very important point is all of MD Clone sits on-prem for us. So it's inside our firewall. It's not anywhere outside. There's no access to anyone from outside our system. All of those, kinds of things make it a much easier thing to meter. And we set up, like we do for every kind of software, a set of privileges and a methodology of how to get it in a user policy. All of that is in place. So and maybe Ziv, you should answer better. You actually know more about the security than I do.
I think you covered this perfectly, Mike.
I'm muted, of course. Jumping off of that or building on that question, I guess, can you talk a little bit about, maybe this is for Viet or Mike, how that enables more collaboration and kind of cross-functional, thought partnership?
You mean the
being able to access that data, that you have?
Yeah, no, I mean, I think, and I think a little bit differently than a regular, point of care clinician, because I'm fully in research. As my bio stated, I spend part of my time doing the lipid clinic, but I am a full-time researcher, and so I think of data a little bit differently. And absolutely, collaboration occurs when you have access to data. And, Peter and I have talked a little bit about how do you leverage the synthetic data, because I think that's just as valuable, if not more so, to be able to think of it's basically Intermountain data, but it's de-identified and you've got the aggregate data. And I mean, that's fantastic. In my mind, that opens up a lot of worlds when you can amplify what you have with a similar system, or even if they don't have a similar system, the data libraries, as long as they match up, you can really start to answer some questions across populations. I think it's a fantastic way to do research, but clinically within Intermountain, that's been neat as well, as I've worked with not only our researchers, who we already share a lot of the data, and many of our analysts don't look specifically at any one individual. They're also kind of looking at it in aggregate already, but to be able to even pull the data in the first place, that's the tough part. So to have it, I'm not so worried about access, because we, as Mike said, I mean, at home, here I'm doing this from home, and I have to go through a firewall. I have to do VPN just to get iCentra, and through that same firewall is how I access MDClone. I can't just get to it from anywhere. I have to use it through a secure firewall. So I guess anyone could be evil or bad and use any data that way. But I think there's so much more room for benefit and collaboration than any, I guess, astray or data misuse.
And I would add one quick thing to what Viet had said. So we do take queries and evaluations that are generated through MDClone and put them back into directly back into our CRM tools that we monitor patients with. We can also send them back to the EMR and notifications. So we can guide and sort of bring a care path up and running for specific portions of it and get the data back to the caregiver at the point of care, which is the thing that has typically been a big miss for healthcare. Even when you go out and are able to identify cadres of patients or a particular next action that you think is appropriate, we have a lot of trouble getting that in the eyeballs of the person who's seeing a patient today.
So helpful. And I guess just taking that one step further in terms of this theme of collaboration, can you talk a little bit about how it maybe enables collaboration outside of Intermountain with other organizations, or beyond your organization?
Yeah, I can take a stab at that, because we're just starting to do that process. The synthetic data piece allows us to do this in a much more rapid way, in the sense that we're not sharing PHI if we're going across that. We're still working through the final details of exporting our data out, but we have combined our data sets successfully with a couple of hospitals in Israel, but we did it inside Intermountain's firewall. So they sent it to us as synthetic data, and we made combined cohorts of patients. We're in the process of dotting the final I's and crossing the final T's to be able to have our data be shared. That's the potential of the global network for MD Clone. As synthetic data, there are northward of 55 million patient data sets in there. It would be, even without having to share data in the, sending it back and forth, you could run a combined query at each individual site and get the final data out across a 55 million patient data set. So there's enormous opportunity to solve very big problems very quickly, and it stops the need to produce a large certified single instance de-identified data set, that's a lot of work.
Like we might have a question from the audience. I don't know. Is that Ty, you want to go ahead?
Hey, Ty Gluckman calling from Providence up in Portland, Oregon. Kudos to you on amazing work, Viet. It's great to see you. We know each other from other channels. I guess I have a question. You guys are solving major problems because obviously if you can't delve into the data, it's really hard to understand the scope of the problem and where to begin in solving it. But to what extent are a lot of your clinicians or administrative leads using this data, and what's the connectivity back to drive clinical decision support or other care pathway development, et cetera? I understand the fact that you're able to get all the data together to be able to understand the scope of the problem and where you start, but is this also accelerating other work in terms of the direct problem solving in the EHR, et cetera?
Yeah, I'll take a stab and then I'll let Viet comment as well. So it's a little bit of both, and it has been a process for us. So probably the most developed program is our kidney care program, and we actually started with our care path. And our goal, even before we wanted to put a lot of AI into the potential thing of finding out whether we could do something better, was to get our clinicians to behave uniformly. Our organization, we're famous for care paths, right? And our care paths are really cool. I just wish we could actually say that everyone was following them. Okay, we have a lot of variability amongst our clinicians. So step one was to identify the care path, find people who are off the care path, and redirect care to get people on. And after that, I think there are a lot more sophisticated questions that you could answer and ask. I'm not even confident that most health systems have an adequate training set, given the variability in the care that they give, to even put AI on this problem. So step one for us is really to get people back on the care path and to implement the things that we all agree on, their national standards. We just want to get all of our caregivers to do that. So step one was to be able to do that kind of work and make sure that that information got to the point of care for a coordinator, for a nephrologist, for the groups of folks who kind of work our lists. The next step actually is to automate portions of this. And we're working on this right now, which is that we identify people who are off the care path, and we identify the steps to bring them back on the care path, and we automate that process. And what I mean by automating is that we work towards getting a order set that we placed in the system for ordering meds and everything that needs to happen, a documentation that's required for coding for the care path, and the information that needs to go inside the record, and we offer it up to a clinician with a OK button. And this is, we're still in the very early phase of doing this, but it literally is, do you want to put this patient back on the care path? These 5 steps will occur, press this button. And that's where we kind of see the endpoint of this sort of data going. It's effectively an easy button. And although our clinician may not necessarily want to completely follow this care path, they're actually okay with it. So they have the choice of pressing this one button or manually entering their deviation from the care path. So our thought process is that we have the opportunity to nudge care, starting with this data and moving all the way through the execution with effectively kind of an easy button. I may not have answered your exact question, but
No.
I did go on for a while there, sorry.
Super helpful, thank you.
Great. Well, if there's no other questions, I'll give you one last chance as I kind of ask my final question to any of the panelists who would like to respond. Just, as you think about your colleagues, your partner organizations who are maybe starting out on this journey, like any words of wisdom, advice, any challenges and how you maybe overcame them. So take your pick there, just any closing thoughts that you want to share with our participants today.
Well, you know, Mikey did a fantastic job of answering Ty's question. And I will say that the kidney care program is like the bigger older brother or sister off on the pro leagues there. And I feel like I'm still in the peewee area watching this go forth. My
Not
thoughts,
true, but that's fine.
no. I think that it's certainly maturing, but the thing is that it's intentional. And that's the thought that I would put out there, is that as you move forward in this, if there's anything that you've heard that's even remotely exciting about this, and it should be exciting, you need to be intentional about it. I've somewhat stumbled onto this mainly from a research path, and it's grown over to the clinical side where I work in lipids. I'm definitely not in an area where we're as mature in our thinking and our intentions as Mike and the kidney care group is. And so actually we've been learning and siphoning off some of those great lessons that they've learned. Peter has been helping mentor me through my thought process and helping me think how to grow our lipids to do the same thing. I mean, you know, to be fair to what you said, Mike, is we know that guideline-directed medical therapies and guidelines aren't followed uniformly anywhere, but we do also know that if they were followed, just that alone levels up care. So when we think of care process models, identifying, you know, what you don't measure, you can't change. And we have these care process models. Identifying who's off the path will often by itself lead benefit to our groups. So just being intentional about this, know what you want, you know, set out with kind of the end in mind as you think about data and what you want to do with it.
And I would agree. I think you need to be intentional about the things that you choose. I would say that this is very different than data systems that we brought up in the past. You know, in the sense that we brought up all of this data in 3 months. From start to finish with MD Clone. So, you know, that it's much quicker. So I would encourage people to include as much as they could up front, and include the things that we have always kind of known drove healthcare, but we never really looked at in our data sets. Like, where does this person live? Are they employed? You know, where is the closest pharmacy? Things like that actually drive a huge amount of healthcare. So including that kind of data up front, as much as you can get in there. We want to get our remote patient monitoring devices in there as well. They're just time-stamped information, so they fit nicely into MD Clone. You can ask very unique questions. You know, it's like, this person had a fall today, and the heart rate monitor they have and the accelerometer on their watch tends to suggest that they're not responding appropriately when they get out of a chair. So maybe we need to hydrate them. And so those kinds of things are new things that we're trying to do. So I agree with you be intentional, make sure that you go for a big data set, because it actually doesn't take that long to get set up. And then pick a pretty broad range of users. Don't just, you know, pick one sort of champion doc. This is a tool that can be used for everyone in clinical care, and it can be used by your administrators, your folks in finance, the broader group of people that you get out of this. And importantly, in our case, it also got people to talk together. So when we had to set up this kidney clinic, we moved from a fee-for-service, you get paid by the visit group of nephrologists, to a group of people who were tasked with caring for everyone with kidney disease. And we told them not to worry about how many people they saw in clinic. If they could decrease the number of hospitalizations, we were all good. So that required getting everyone to agree on the same data, including administrators, finance folks, you know, all those people who are telling you that you should have gotten this many RVUs today. This data brought them all together. We had a discussion. We changed the pattern of care. So, you know, think big on the data, and be very inclusive of the people you would bring into the process.
Great closing thoughts. Thank you all so much for your time today. It was a pleasure. Have a good afternoon and rest of your week, everyone. Thank you for joining us.
Thank you.
Okay.